Great, thank you. It's a pleasure to introduce today's speaker. Audrey Dorélien is an assistant professor in the global policy and the social policy and policy analysis areas and an affiliate of the Minnesota Population Center. Her research agenda strives to elucidate how human population dynamics and behaviors intersect with environmental conditions to affect health. Her current research focuses on the effects of early life exposures on health, both in the United States and in sub-Saharan Africa. Professor Dorélien has also conducted research on spatial demography and urbanization with a focus on implications for health and climate change vulnerability. She is currently the co-investigator of the Minnesota Social Contact and Modeling Study. Today, she will be presenting on quantifying social contact patterns in Minnesota during the stay-at-home social distancing order. Please unmute and join me in welcoming Professor Dorélien.
Hi, it's very nice to be here, and it's actually nice to see some familiar faces that I have not seen in a while. And Casey, thank you for that introduction. So before I start, is my volume clear? All right, great. So this is really one of my research strands where I've really focused on the interactions between human population dynamics and infectious disease dynamics. And actually trying to quantify social contact patterns is something that I had started in earnest in 2019 before the COVID pandemic, but I will, and I'll mention briefly some of that talk. Okay. So in terms of my motivation for this, it's really the fact that we're living in an era of many emerging and re-emerging infectious diseases. And in particularly, there's been a lot of respiratory EIDs. And SARS-CoV-2 is just really one of the latest. We've seen SARS, MERS, H1N1. And actually, when I first really was starting to work on this, my big fear was, and I guess it's still a fear, thinking of an influenza pandemic. And what these respiratory EIDs have in common, along with COVID, is that many of them are primarily spread through close interpersonal contacts. And then therefore, many of the non-pharmaceutical interventions that have are really trying to limit these interpersonal contacts. And then these NPIs, as we've all become aware, are especially important when the vaccines and treatments are not yet available. So then we really need to measure and understand these social contact patterns. And what I mean by social contact patterns is really information on the number, duration, nature of the contacts. And it's really important to understand these contacts by age, sex, and also other social demographic characteristics. And it's because interventions that rely on social contact data. So I mentioned these NPIs. So really the effectiveness of these NPIs, and I guess I should say physical distancing measures, you really need some information on these social contact patterns. But I'm not sure, and I think there were some talks I missed earlier this week, but even studies that look at optimal vaccination distribution or vaccine booster schedules often need information on these age-structured contact patterns or these social contact patterns. And then why focus on age? So once again, with COVID, we've come to realize or reinforce the fact that disease transmission can vary by age, but also the morbidity and mortality varies by age. So I think with COVID, it's very clear that mortality and morbidity almost increases exponentially by age. So you really want this information disaggregated by age. So how can demographers help? So really, you want to be able to collect data on disease relevant social contacts. And then, social contacts patterns can actually be summarized with age structured contact matrices. So matrices showing whom interacts with whom. And I think, I'm not sure if Dennis and Aisha on Monday, when I was looking at the schedule, probably went more in depth into this. But basically, these age contact matrices are a key input into many infectious disease transmission models. Specifically, they can impact there or not. Okay. So in terms of existing data and approaches to measure social contact, the most cited study has been the POLYMOD project. And this was data collected from 8 European countries in 2006. So this data now is over 15 years old. But if you see in terms, especially in the past year and a half, I think like the number of citations to this data source has doubled. But basically, they use surveys, paper-based diaries to record data on contacts that occurred over a 24-hour period. And they recorded information on the age and sex of the respondents, but also had information on the contacts, specifically the age and sex of the contacts, the location in which this contact occurred, the frequency, duration, and type of contact, so physical or non-physical. And then since then, there's been a plethora of these studies, so Vietnam, Zimbabwe, Russia, Belgium, but until very recently, not much in the US. And this is just to highlight that these POLYMOD surveys are widely used or have implications for infectious disease. So if you go to, I can send my slides, so you'll be able to click on this link. But the Socrates tool, you can actually select some of these different POLYMOD matrix, social contact matrices, and actually create your own custom age groups, specify, filter some conditions, and actually generate some matrices. And I think they have some basic disease modeling also incorporated in this. And I guess I just want to say that one of the things with my study, I'm actually also hoping to post the data used to create these contact matrices in that same repository in Zenodo. Okay. Other approaches. Another one that I've seen in the US that's been cited a lot is by Prem et al. That uses a synthetic contact matrix. So it basically takes their POLYMOD and augments it with information on US household size and also information on workforce labor participation and school and other terms. So that's one approach, but I don't think it's been so great. There's also, like, reviewers have also mentioned, oh, what about wearable sensors? Where the use of wearable sensors, it's good, but it's limited. So those can really capture social contacts in an enclosed setting, so within a school or a hospital, but it's not really feasible for, like, a city. But then some people may argue about, hey, what about these contact tracing apps or some of these mobile apps. The issue with those are a great step, but once again, unless every single person has those same apps, you are not necessarily, and then you also, because of privacy information, you don't necessarily have information on the age, sex, and all these demographic information that you want and need about these social contacts. But then mobile data has been used, but it's really the most useful uses is really in trying to understand big movements across region, and also with help in terms of introduction or for disease spread. All right. So overall, there's a lack of empirical data on epidemiologically relevant social contacts from the US. Oftentimes, researchers have had to rely on unrealistic assumption or data from other countries. So to some extent, I'm not sure, it may not be by much, but then it does mean that for the US, or allow for MPIs or allow strategies may be suboptimal. And I think what's been very vexing is that I think other countries, like the UK or Belgium, or during the pandemic, were capturing this information at every 2 weeks. And then for the US, we just do not have this at a national level. And this is just to highlight an example of papers that are relying on this. So this was a paper that just came out in March in Science. I think when I was glancing at it, there's a part where they created contact matrices for infection, once again, based on data from Europe and China. So, you really do need this information. I think Alison Galvani in some papers in Science also mentioned that like that's been one of the limitations, that we do need this data. So pre-pandemic, so there is some information. So, Berkeley's Emilio Zaghini, who came from Berkeley, he actually did use American time use data to create an age structure duration of contact matrix. So here he had used 2003 data, but here his matrix shows the duration, not the number of contacts. And the time use data set, I do think it's a great resource, but you are limited where there's no information on the age of non-household member contacts. So he had to rely on some assumptions. There is this paper in 2011, but that's just based on 4 counties in North Carolina during one influenza season. And I actually do have a paper forthcoming that I also used the American Time Use Survey, and this is the paper I was working on before the COVID pandemic, where I was using the Time Use Survey and the fact I had data from 2003 all the way to 2018 to really look at the demographic, spatial, and temporal variations in age pattern of duration of contacts. And then from that data, I was also able to create some age structured contact matrices, but I was only able to show the number and duration of contacts for the home setting, because it's only there that I had information on the age and number, the age and the number of contacts. I do plan on following up with Emilio and using his strategy to create duration of contact matrices for household settings. And I'm actually really interested in looking at the latest data during the pandemic to see how it compared to these pre-pandemic findings. And then also, like, what's the best that's out there, published out there right now, is work by Dennis and Aisha, which I've been a big fan of, where they've been looking at contact patterns across 6 US cities. But here, in contrast to what I'm presenting today, their methodology was a bit different, where it was a online sample for adults 18 plus. And I think you can correct me if I'm wrong, Aisha, where you had detailed contacts on up to 3 non-household contacts. Okay, so any questions so far? Because I'm about to dive right into my study. Okay, all right, so
I think we're doing great, Audrey. Super
right.
so far. Thank you.
All right, great. So in terms of the research aims, so the aims were really to update and adapt the POLYMOD survey for use in Minnesota. So used during the COVID pandemic, but I think some of the other collaborators, we actually really want to keep on collecting this information, because it's not just for COVID-19. I have colleagues who work on pertussis and other respiratory illness, that these contact patterns would be useful. So specifically, for the first wave, I was really interested in figuring out what is the mean number of daily contacts during the stay-at-home order. How does it vary by age, gender, race, ethnicity, and region? And then also generating and describing age-structured contact matrices, and then also being able to compare them to some of the pre-pandemic matrix. So specifically in this presentation, I'll compare it to the UK POLYMOD, but I do also in the working paper compare it to a few to the synthetic US one, and also compare the ATUS home matrix I had with what I find here. So in the Minnesota social contact study, the wave 1. So I guess the first thing, participants were recruited from participants who had participated in the 2019 Minnesota Health Access Survey. So that survey was from August to November 2019. And that survey had about 11,000 households and was representative of Minnesota. So about half of those respondents said that they were willing to participate in a follow-up survey. So those were the actual participants that we use for our sample. So in the MNHA, the recruitment method, it was a combination of both telephone and address-based sample. So when people were contacted on telephone, they were given the option to continue the survey by telephone, or they have the option of using the link to complete the social contact survey online, and then people were sent the information on how to complete it online by mail. So the wave one was during really that first lockdown period. So it was we collected data from April 17th to May 17th, and we sampled. We took half of the sample that was willing to be followed, that agreed to a follow-up. But then after data cleaning and non-response, we had about 1,600 households with about 2,000 respondents. And that's because this is one key difference in our survey compared to others I've seen. We had both adults and children. So basically, how did we get children? So we knew the household composition of the household. So for half the households with children, we asked an adult to respond random on behalf of a randomly selected household child. So they, but then they were also given the option afterwards to also include their own contact information. And an adult was anyone over 18, children were under 18. All right. So what's considered a social contact? So in our survey, and I think we follow pretty close or very similar to the POLYMOD definition, was either a two-way conversation with 3 or more words in the physical presence of another person, or for children who are not speaking. So for example, my toddler or infant, one-way conversation in the physical presence of another person, or a physical skin-to-skin contact, so handshake, hug, kiss, contact sports. So the survey collected information on the total number of contacts. So for all respondents, we asked on the previous day. And it was all, we asked them to report contacts from the day before. How many total number of contacts they had, but we also asked them how many contacts they had in work and school settings specifically. And I'll go in more detailed. But the survey collected detailed information on up to 30 contacts. And that's because really, like, we were worried about burden, and especially for some of these phone surveys, going systematically through, more than 30 contacts takes a lot of time. So for each contact, the respondent was asked to give the age, gender, the location, so home, school, work, transportation, the nature of the contact. So it was a physical or conversational, information on duration of contact, and then frequency, daily, 1 to 2 times a week, 1 to 2 times a month, and so on. And in the first survey we did wave, we did not have this information, but in wave 2 and wave 3, we did also collect information on use of PPE, so we know whether or not they were wearing a mask during these contacts. But then and this is one thing that with the other collaborators on the survey, like, this is not the way I would have ideally wanted to do it. But basically, for respondents with 10 or more work or school contacts, and these I'll call work outliers or school outliers, we did not collect detailed information on their contact. We did try to collect, especially in wave 2s, and after that, we collected more aggregate information on these contacts. So I'll explain how I address this. But then, and I'll talk about this in the limitation, but I think for all contact surveys, I think one of the big limitation is how to address participants with like large number of contacts, because some people may report like 100 contacts. So more details about the Minnesota Social Contact Survey and the survey methodology. And I think Casey may put this in the, I'm not sure, the shared folder. You can see this paper that shows the survey instrument and provides a little bit more detail. So to the fun stuff. So this is actually where, so I basically had to impute the contact ages for school and work outliers. For school outliers, it was like, this was during the lockdown period. There were very few, but daycares were still open. So less than 1% of my sample, about 17 children, had more than 10 work or school contacts. So for these contacts, we assume that the contacts were the same age as the respondents. For the work contacts, what I did is that I basically randomly sampled work contacts. So for these work outliers, work contacts of other essential workers that did not have more than 10 work contacts. But basically, I matched them based on the 5-year age group and the sex, on the gender. So, and that's because the age distribution of the work outliers and other essential workers were the same, pretty much the same. And then the only variable that was actually predictive of being a work outlier versus an overall worker was the sex, female, and that's actually because the women were more likely to be essential workers and also more likely to be in like healthcare or some of these education industries. And then when I including the imputation increased the mean number of daily contacts between working age respondents and their working age contacts, which makes sense because if I had not done that, I would basically undercount those because I did not have, I was missing those ages, and we knew that those were the essential workers with a large number of contacts. And then I actually used another, as a sensitivity analysis or robustness check, use predictive means matching to also try to impute the missing work contact ages, and the results were pretty much the same because I also matched it based on the age group and the sex. And so this is where my method differs a little bit from Dennis and Aisha's method, but in the discussion, maybe we Q&A, we could talk about this some more. So in this paper, I really just focus on the descriptive analysis, where I'm going to show you a histogram, the distribution of the total number of contacts. Then I calculated the mean number of daily contacts based on different characteristics. And the mean, I used sample weights. So I'll highlight the impacts of the sample weights. I did also run a negative binomial regression, and you'll see the IRR. But that's because, once again, here, this was a purely descriptive study. So I only control for structural factors, specifically the survey mode, if it was telephone or if it was web, and also day of the week. So if it occurred on a weekend or weekday. And then all my age contact matrices were created using the social mixer R package. And I also will show you the Q index. So the Q index is an index of age assortativeness. So that means that if there's homogeneous mixing, that respondents equally interact with individuals in all age groups, then you'll have a Q index of 0. But if respondents only interact with people in their same age group, then you have a Q index of 1 equals 1. Yeah. So as you can see, and I think Dennis's and Aisha's results show very similar patterns, distribution of total number of contacts is skewed. So you do see that most respondents had, the median was 3 contacts. The unweighted mean was 5.4, weighted means was 5.6. But you do have a few respondents that do have a high number of contacts. So this is just to show you that during the stay-at-home period, I guess in Minnesotans, we think of ourselves as very civic-minded, that like, hey, like we follow the rules, we're going to do the lockdown. But even when you compare Minnesota, the average number of daily contacts, it was 5.6, and that's far higher than other settings during their respective lockdown. So this is during those first wave. So Luxembourg had reduced that to 3.2 daily contacts. The UK was 2.8. Wuhan, China 2. But that's important because in Minnesota, I think one study said that like or who was considered an essential worker may have been a bit permissive, where up to like maybe 78% of the workforce could, in a sense, be an essential worker. So sorry about this table. This is because for the paper I'm limited. I'll show you some figures next, but like the only things I really want you to focus on, and you'll see a series of these screenshots from this table, is here you can see the unweighted distributions. So that allows you to see the effects of the weights. This is the weighted means and the unweighted means. But the key in the, and I'll show this better in another slide, is that the there was not, the age groups did not have like the mean number of daily contacts was not homogeneous across age. There were some serious variations. So this might show a little bit better. So in this figure, I have the 5-year age groups on the x-axis, the mean number of total daily contacts on the y. But what I do is that I show you the breakdown by location. But overall, you can see that like this 40, sorry, let me move some of my zoom. This 40 to 44 group and also this 50 to 59, they had by far the highest mean number of contacts, and that's really driven by the fact that they had work contacts, while people in the younger age groups obviously like didn't really have work contacts. And I think actually for this 35 to 39 year old group, I'm almost wondering whether or not they have few work contacts because of maybe like childcare duties, having to stay home. This is another way to view this same information. So here I look at the share of contacts as a percentage by location. So once again, you can see for the younger age groups, so those below 15, actually below 20, the majority of those contacts were taking place at home. Also, for those above 65, the majority of the contacts were taking place at home. But for the people most of the people, middle-aged individuals, the majority of contacts were not at home. As I said, except for this 35-39 age group, it could be because that's the age group most likely to have young kids. So if I look at variation by gender and type of day, once again, you saw that women tended to have higher number or mean number of contacts compared to men. And then you had a higher mean number of contacts during the weekday compared to weekend. Oh, this is actually where it gets to me a little bit interesting, some of this spatial variation. So it's not, I'm seeing some spatial variation in contact patterns. So when I separated by non-metro and metro area, you see that overall in non-metro area, the mean number of contacts tended to be higher than in the metro areas, with the exception for this outskirts of the Twin Cities. But I'll show you that the outskirts of the Twin Cities may actually be more similar, culturally similar to the non-metro areas. And actually, if I once again try to look at it by location, so here, sorry, it's sorted by mean number of contacts, and almost all of these, the top here are non-metro, except for this outskirts of the Twin Cities. But you can see that the non-metro areas, especially because during the first wave, most of the pandemic was hitting the cities, they were not reducing necessarily their proportion of work contacts as much, while in the metro areas, most of their contacts were in their home setting. And this is actually just showing that maybe cultural differences may be driving the metro non-metro pattern. So you can see that the metro pattern so I guess I'm highlighting this because what's become very clear in the past year is that there's been this geographic polarization and that geographic polarization might also, you may see in terms of behavior, mask wearing, or and also like I guess following the stay-at-home order. And I see a question about, does the Minnesota social contact pattern include precautionary measures? So I'll have to see. So I do actually have information on everyone's zip code. So I can, and I have the date, so I can try to see if whether or not people who were in high impact areas were restricting, so I guess like prevalence dependent behavior, where it's like, hey, if risk is high, I may have fewer contacts. So this is why it might be interesting to see how these spatial contact patterns change over time, because in future waves, then it did spread to the non-metro areas to see if we're seeing some of these same patterns. But the non-metro, the outskirts of the Twin Cities are actually also very red. So I am wondering, and they were actually also impacted. So the fact that they had high mean number of contact patterns, I'm wondering if it could be some of this politics or cultural differences, or also looking at occupation, or there's a wealth of other information I may want to look at. All right, so my results for race and ethnicity are also very interesting. So there are some surprises and some things are not surprising. But first of all, I want to say that one limitation of this study is that even though the MNHA was supposed to try to oversample BIPOC population, it really did not do a great job. And I think it's because it actually focused more on oversampling non-metro areas. So you can see that, like, without adjusting for the weights, most of my sample is white, and there's very few in Black or African American. So here you can see that the sampling weights does have a significant effect on the distribution. But basically, I see that respondents in Black households had about maybe like a little more than 2.5, 3 additional contacts relative to white. Same for Asian Pacific Islander. So in Minnesota, we have a huge refugee Hmong Lao population. But this was a surprise where I found that in my data, Hispanic households actually had fewer contacts. And I do have some data from the Minnesota Demographic Center that might help explain this. So it could be that, so as I said, we know that Black households are more exposure to risk, but also Hispanic household. But then one difference is in the kind of the work composition, where Hispanic households may have been more vulnerable to layoff. And that's because actually many Hispanics were more likely to be working in the restaurant industries. And as we know, during that lockdown, the restaurants closed. So it was just more delivery. So that might be one explanation, but really I'm working on pulling multiple waves of the data and actually just seeing how some of the data may change over time. But this is something that I was not expecting in my study. So for the age structured contact results, as I said, so here for this, here I do top code the data at 30, and this is something, so even in the POLYMOD survey, I think they top coded at 29. So I ended up having with about a little bit over 2,000 participants with almost 10,000 contacts. So in the cells that I'm going to be showing you, each cell represents the mean number of daily contacts between respondents in age group I and contacts in age group J. I am accounting for sampling weights and also weight for the type of the day. And then all these matrices are symmetric. So that means that the total number of contacts made by respondents in the age group I with contacts in age group J are the same, and vice versa. But you won't be able to obviously tell they're symmetric in the matrices that I'm showing you, because I'll be showing you the mean number of daily contacts, not the total number of daily contacts. And I did use the 2019 ACS, Minnesota ACS data to help make it symmetric. So, and I'll address your question, Josh. And so, Josh.
Oh, I'm sorry. When we type in chat, I usually mean for that to be end. I'm sorry. I'm just doing it as I'm in real time. So
okay,
sorry.
so I'll save.
You don't have to read the chat. You don't have to read the chat. No,
all right,
sorry.
Perfect. So what does it look like? So this is the overall age structured matrices. And here I use the color. So the lighter the color, the lower the mean number of daily contacts, and the more orange, the higher the number. So if you look at this matrix, some of these, you see some of the features that you do see in the pre-pandemic, some of these POLYMOD matrices, where you see that the greatest amount of mixing takes place between respondents and contacts in the same age group, so along the diagonal. But you also see some of these off-diagonal patterns where you see contacts. So these represent parents interacting with children, and children interacting with parents, and vice versa. But then, and here, these are like working age contacts. But there are some differences, and when I explicitly compare it with the POLYMOD, it'll be more obvious. But there are some differences where children and young adults no longer have the largest number of restorative contacts. So before, you always had this strong diagonal, but children, because of school, had way higher, at least in the European setting, had way higher number of contacts than adults. This is not necessarily the case in Zimbabwe or other places where there was more mixing. And here in the next few slides, I break it down by setting. So you can see that the home, so contacts at home really dominate and make up most of the overall age contact matrices. So once again, you see that people interacting with other people the same age, so children with siblings, parents, or people with their partners or roommates, and also the children and parents. You do see that there is some working age population having, so the essential workers that were interacting at work with people at work. School, as you expected, this is during the shutdown, is almost totally blank, with the exception of actually most of these contacts between the people in ages 0 to 10, it's really driven by children under 5 because many daycares were not necessarily closed. They were considered an essential setting. So if I had done 5-year age groups, you'll see that almost all of this would be with kids under age 5. And then you'll see some of the, so in the school setting, some adults interacting with other adults. So it's parents with the drop off, and also maybe some teachers interacting with each other. And then in the other contact, you do see some of that interaction along the diagonal, but also a lot of, this one was, I think, the most homogeneous in terms of the Q index being closer or to 1. So if I were to compare it to the pre-pandemic, to a pre-pandemic matrix. So here, for simplicity, I'm comparing it to UK POLYMOD. We don't know necessarily that the US look like this, and it probably did not. But I did, so here I'm comparing the UK POLYMOD with the Minnesota Wave 1. And here I have the percentage change matrix. So the key feature is that except for one cell, basically there was a across the board reduction in the mean number of contacts. So red means reduction, blue means increase. So for example, for children under 10 interacting with other children under 10, that's a 67% reduction. So basically, there's some patterns that are very noticeable. So basically, respondents over 60 really reduce, and which makes sense, interactions with respondents in younger age groups. So I think that on average in these cells, that's about 70% reduction. And then also due to school closures, you also see significant reduction in the number of contacts that children had with other children. So, here ranging from 67% to 83% reduction. Oh, sorry, Siri thought I was talking. And And then, but then I guess there was a across the board reduction, but that magnitude was not homogeneous across all age groups. So then here the working age population did reduce their contacts, but because many were still essential workers and working, that reduction here was not as great as for some other or between some other age groups. So that's that. And then actually, I just wanted to give you a little preview to show you that like contact patterns are changing. So there was the wave 2, which we collected information between September and November 2020, where there was some, it's not across the board, school openings. So you do start to see the more interaction of school age children interacting with each other. And you do see that the working age, like some people were starting to go back to work, things were opening up more, where you do see more of these working age interactions. So this is just to compare the wave 1 and wave 2. And there was also wave 3 data that was collected in February, but I haven't plotted this yet. So in terms of implications for COVID, it's really important to identify the demographic groups that have those high contact rates. So really like which age groups had the high contact rates, and also like racial ethnic groups, some of these regional differences. And actually I don't show this data here. Like I had information on people's employment status and occupation, and you definitely see some variation there. But it's not just that you want to target people with high contact rates, but you also want that information also needs to be put into these infectious disease models, because just because someone may have high contact rates, there's that interaction between contacts and susceptibility and infectability. So that transmission. So you also, it's not necessarily the case that the group with the highest number of contacts may be driving the most transmission. So you do need to put it in these models. But then also showing you the difference between wave 1 and wave 2 just highlights the need to really continuously monitor the contact patterns because they can change. And actually, this is not published yet, but then I did work closely with the Minnesota Department of Health, who are collaborating with folks in the School of Public Health to do our COVID-19 modeling. And these matrices were implemented. And I think prior to collecting this data, I realized that some of the assumptions that they had been using was faulty, because for instance they had assuming across the board 80% reduction in contacts, and as I said, as I showed you here, it wasn't an across the board 80%. So the very first models that they were doing, they had to adjust a bit, where actually working age adults did not reduce it. And I think they also thought that the mean number would have been lower than it was. Yeah. In terms of limitations, I think for me, some in other contact matrix or surveys, it's really best practices for obtaining detailed information for a large number of contacts. So in my particular survey, I may be underestimating the number of contacts. So that 5.6, the fact that that may actually be an underestimate is worrisome. There is that social desirability bias where people, you know, even like we're aware that like there was this lockdown, so they may not want to admit that, you know, they were having huge parties at home. It was retrospective survey, so I think there's some evidence that there might be some recall bias, but here I'm not as concerned because they were just asked to recall contacts the day before, and during this time period most people did not have that many contacts to remember. And then in my first wave of the data, I do think there might be some tendencies where I think people might have failed to report some household member contacts. So for instance, I noticed some children that were for instance, under 10 with no contacts. So in those cases, we did some data cleaning where it's like, okay, they had contacts with their household members and stuff like that. But I think sometimes people were just thinking of non-household member contacts. So in wave 2, in the future waves, we had some more prompts to make sure to correct for that. So to make sure that people didn't fail to report their household member contacts.
Great.
So
yeah. Let's stop right here. We're going to take away your acknowledgements. People can read them, just because we're a little bit behind on time.
Okay.
Let me just, in order to make some decisions about how to proceed, we have three kind of things happening in the next 15 minutes. One is we want to have discussions with you, Audrey. The second is that we had kind of planned for people who were super interested to have a little continued discussion with you. And the third is we definitely need to take a break.
Yeah.
So I'm suggesting we eliminate the middle thing. We do a couple of questions now, a little bit shorter, and that we also try to begin a little bit later our next session in order to get a break. Does that sound, Aisha? Can you kind of give me a check on that? What we should do?
I guess my only hesitation would be about beginning the next session a little bit later, given the schedules of the speakers in the next session.
We might not know exactly. Okay, so let's try to do about 7 or 8 minutes with Audrey, and then we'll have our break, and then we'll try to begin on time. That sounds great. So I'm going to be super tough here. I'm going to leave discussion. I'm going to steal Casey's prerogative, and I'm just going to call on. We're going to have a little bit of internecine discussion. Is that the right word? We have Aisha and Dennis who are working on this stuff, and we're going to kind of watch them talk to Audrey live. So why don't Aisha and Dennis, you guys ask your questions, and Audrey can answer them, and we're going to cut out all the trainees, and we'll see how terrible that is.
Sure, that sounds good. I had a question that maybe other folks had too. Audrey, you talked a little bit about racial and demographic sort of differences across groups. So we actually saw this in our survey too, where Hispanics had, I think, Dennis, you can correct me if I'm wrong, they had lower contacts than whites in sort of the last wave, but there was variation across time. Do you have thoughts on how things might be changing in Minnesota over time with respect to, as things open up, who goes back to work? I think Josh has a related question about who's answering these surveys and what we're capturing. So
so I think that's definitely at play. And I think for me, I'm actually this summer going to focus more on these racial and ethnic differences, because I think that's been missing. And I do think there's some other folks that have been looking at this. So one thing is that the fact that we saw those regional differences, there's also an interaction between the race and spatial differences. So a lot of the ethnic minorities are in the metro areas. So I feel like even if they may have more contacts, the metro areas, as we said, had fewer contacts. So I think I really need to look at that interplay and of just the location of where the people are based and the race. And I do think that I need to look, I'll go back from other research I had done in my ATUS, that pre-pandemic. There I had found some interesting stuff. So in my pre-pandemic analysis of the time use data, I had found that Black had the fewest duration and number of fewest household member contacts, and overall fewest duration of contacts. So that was a little surprising. But then in that paper, when we had looked at a little bit more of the occupation, we saw that even though they may have fewer contacts, they were more likely to be employed in occupations that required high physical proximity. So they were in riskier. So it's not just the number of contacts. Blacks had riskier number of contacts. And then there, when I had looked at Hispanic actually had the greatest number of household member contacts. So I think there the household size may play a role. And then they also, compared to whites, had more, they didn't have, during the pre-pandemic, so when there was no difference between essential worker and non-essential worker, they tended to have the overall similar duration of contacts at work as white, but once again, those contacts were riskier. So I think that's just something to think about. So I think now during the pandemic, I do think for the Hispanic, if they were more likely to be laid off, that might help explain, but maybe later on in the waves, I'll see in Minnesota if that might have increased. And as I said, I think Black population was actually way more likely to work in like healthcare or nursing home than the Hispanic. So I think it's just to remind that like these ethnic compositions, like they may actually vary from city. Like the Asian population in Minnesota is very different than the Asian population in New Jersey or California, for instance. So that's why like I have information on like employment status, occupation, household. So I think I'm really hoping to actually dig more into like do more, now use those regression to really kind of understand what is driving the social demographic differences in the mean number of contacts. So that's actually analysis, and I'm hoping to pull the data. The issues that if I pull the data, I just don't know if I have enough power to really to compare across waves, but really I'll be able to maybe pull things are systematically different throughout the whole period, but that's definitely something. And I think I'm not sure if other people know, Dennis, Aisha, and I are joining, or we joined force to try to get an R21, but we are going to be working on an R01 proposal, and I'm hoping that part of the R01 proposal is to really try to oversample and actually get more information on the social contact patterns for these groups. And actually one thing that I would love to be able to do, but I'm not able to do in my data, is actually create age structured contact matrices by respondents, race and ethnicity, because I think in our reality there is a lot more segregation, and I think we've seen how separate, so maybe they may look different. And right now all of these disease models, when they're using the population overall, they may not be capturing some of these patterns or for some of these groups.
Okay, Audrey, let's stop there with this super interesting note to end on. And if we can all thank Audrey, if you can be as expressive as you can, turn off your mute, show your face. Thanks so much.
Yeah, and can I say that I'm looking for feedback, so people feel free to email me at dorélien@umn.edu if you want to read. Like I really,
and Audrey,
are you looking
for collaborators?
Oh yes, I have data. So I actually, I would love some collaborators. Yeah, so I do. Yeah, as I said, if people are interested in working or collaborating, definitely reach out. Yeah.
Super.
And
Thanks
Audrey, there are
so
some
much,
more
Audrey.
questions in the chat. Just to be sure you look through the chat if you're interested in feedback. Some people.
Okay, so I'm going to make sure to copy that.
So I'm gonna adjourn this session because I want people to. I mean, you've seen me eating cookies and drinking water and walking in my room on day 4 here. This is no reflection on you, Audrey. It's just we've been worn out
lunchtime
by the previous days. So everybody kind of pace themselves, try to take a break now, and we'll resume for our final panel of the day. Thanks so much, Audrey.
Thank you, Audrey. Take care.
Thank you.
Oh, you're welcome.